the board. A special thanks to the doctors presenting our cases this morning, Dr. Polo from Instituto Cancerologia in Guatemala City, that she's joining us for the first time. Dr. Campos from Geraldo Jacoba in Fortaleza, Brazil, and Dr. Mayra Ferreira is well known to us from the Marie Curie from Buenos Aires, Argentina. I also want to say a special welcome and thanks to our panelists, including myself, Paul Goss, Dr. Alphonse Tagian, Dr. Michelle Speck, Dr. Susan Sager will join us online, and Dr. Jennifer Plechter, all from MGH. Dr. Jack Urban from Tufts Medical Center, Dr. Brittany Brischowski from Dana-Farber, Dr. Carol Marquez from Stanford University in California, Dr. Vered Stern, Dr. Jean Wright from Johns Hopkins, Dr. Julia Chu from UPenn, Dr. Cesar Santa Maria from Northwestern University, and Dr. Charlotte Patterson from the Cancer Surgery of Mobile, Alabama. So thank you very much for joining, and also to all our participants online. Please keep your microphones on mute unless you're speaking. Please mute all microphones. And there's one microphone open. It might be Cesar. So that's good. Thank you. If you want to speak, just turn your microphone on. And just as a reminder, the PowerPoint cases we're going to project this morning will be archived online with the accompanying live YouTube video from our discussion. So if you want to go over anything, any clinical trial reference or anything that's mentioned during the tumor board will be circulated to all participants afterwards, so you don't need to take down any notes. And at the end, please, we asked this before but didn't get a great response, but we'd like to ask you all to take a photo of either yourself or your room with your doctors attending today, and please send that photo to Jessica after the tumor board. So thank you very much, and with that we can get started, and I think we're going to start with, is she on the line? She was. Yes. Okay. We're going to start with Dr. Polo from Guatemala City. Dr. Polo, we're just going to share the slides, and when you see them, you can go on, Jessica, thanks. There's Dr. Polo, and here's your first case from Guatemala. Dr. Polo, can you hear us?
Yes, I can hear you.
Please go ahead and present your case.
Okay, good morning. We had a patient that has 54 years old, no risk factor for breast cancer, 5 pregnancies, no hormonal replacement, no oral contraceptives, breastfeeding 9 months. Well, at the clinical exam, she has a tumor on the left breast and upper outer quarter, 6 x 6 x 5 centimeters. Mobile with skin infiltration, axillary lymph node ipsilateral 3.5, immunohistochemistry triple negative, bone scan negative, liver ultrasound negative, chest X-ray normal. So
can I just interrupt for a minute? Can everybody turn off their mic, because there's one mic disturbing everybody on that is still on. Thank you. Okay, go ahead. Thanks, Dr. Polo.
Okay, so we made a biopsy. The report was invasive ductal carcinoma stage 3B. She received chemotherapy, 5 months of neoadjuvant treatment, doxorubicin, ciprofosfamide, and docetaxel, 8 cycles. Then she has no residual disease, and we planned a modified radical mastectomy that was scheduled for 3 weeks later. Day before surgery, a relative indicates that 2 weeks before that date, the patient presents and had headache and right hemiplegia. So we perform a brain scan. Metastasis and brain edema was the report, probably bleeding in all the brain scan. So we can look at these images that all the bleeding that suggests and brain edema. Next, please.
Sorry. Go ahead, please.
Anna. So then she received radiotherapy, 30 grays in 10 fractions.
I'll tell you what, Dr. Polo, can you just leave the questions on the screen? And I might invite some general conversation. I've changed the format a little bit. I'd like to ask some general comments about the case and maybe take into account some of these questions. Maybe you'd like to start, Alphonse?
So about the brain metastasis, I think you did the right thing with 30 gray in 10 fraction. I don't know if we can we answer the question.
Yes, if you want. Yeah, sure.
So your question is what treatment should be considered after this brain radiation, whether we should do radical mastectomy or continue palliative care. You see the question that we struggle with. Once we have a metastasis, what should we do for the local treatment? There is no data to favor one or the other, or at least there is no solid data to favor one or the other. But in my view, we might probably need to do some local treatment, because what will happen, I mean, she might live another year or so, I mean, and she might have a very devastating local failure which can impact her quality of life. I might not go the whole way to do a mastectomy followed by post-mastectomy radiation, but maybe mastectomy might be an option for her. Michelle, do you want to comment on that?
I don't know. I'm pretty worried. I mean, she has brain metastasis. I know you asked the question, how often does cerebral metastasis occur without liver or pulmonary affection? Remember, I don't know if a restaging was done after her chemotherapy. And obviously, I understand you're limited in terms of staging that's available in Guatemala. The standard staging for us with a T4N2 would be a CT scan, chest and pelvis, and a bone scan, or even in some institutions consider a PET scan, which obviously might be a little bit more comprehensive. And so therefore, what I'm trying to say is there could be liver and pulmonary mets at this time that's not been appreciated. Do any of the medical oncologists agree? Is the surgeon talking about metastatic disease?
I think you're doing fine, Michelle, but I had a couple of comments. One of the series I looked at, the triple negative, presenting as an isolated brain metastasis, it occurs, but it's not common. For maybe 10 to 15% of the time, the isolated brain metastasis might be the presentation in the absence of systemic disease. It is possible she has isolated CNS disease, and my concern would be first and foremost what options she might have for medication. It's one series I recall was very clearly said that brain metastasis usually responds well if systemic response is excellent to primary treatment. So this is a little unusual. My most important point, I think, would be to confirm that it truly is triple negative disease, and in that sense there has been discordance with IHC and FISH up to perhaps 3 or 4% of the time, and in giving her the benefit of any doubt, I would want to be absolutely certain that the metastasis or that the disease is truly triple negative and not perhaps HER2 positive disease.
But just for clarification, Jack, you're not recommending brain biopsy, are you?
Well, I might have if it was isolated. Looking at the scans, it looked like it was bihemispheric. I just want to confirm that. But if it was an isolated brain metastasis, I probably would have resected it.
We're very lucky, Jack, just if you wouldn't mind pausing, we're very lucky to have Dr. Rourke with us this morning from NHS. She's a radiologist expert in breast cancer imaging, so I'd like Dr. Rourke just to comment on her CT images that we've seen today.
Sure, just based on the few slices that we have from the head CT, there's definitely the most extensive subcortical edema is in the left frontal lobe. But looking at what slices we do have, there's also significant edema. Looks like right parietal lobe, so I completely agree. It looks like it's bihemispheric. And I see at least 2 enhancing lesions here, one left frontal, one right parietal.
Can you cast any light on this? How often does triple negative present only with brain metastasis as opposed to widespread disease? And have we answered the question? Would anyone like to comment on whether triple negative breast cancer should be treated like small cell lung cancer and CT brain should be a routine in the staging workup of these patients? If anybody wants to comment on that. I don't know if we covered that. Vered, would you like to say what you think about triple negative and brain mets?
Sure. So obviously she had a very nice response in the breast. We don't have pathological confirmation of complete response, but we do unfortunately see this recurrence in the brain as a sanctuary site. I don't know on top of my head what percent of cases. I think Jack mentioned maybe 15% of the time this happens, but I don't know that it should become routine yet. I think we need to look a little bit more at the data before we did that. I also agree that we should repeat the IHC testing just to make sure this is not a HER2-positive tumor that may allow us for other treatment consideration. I also agree that we need to do further imaging to make sure there's no other visceral metastases.
I think a low threshold of suspicion to do a CAT scan is anything symptomatic or physical finding, but I'm not hearing anybody routinely recommending routine CT brain in triple-negative primary diagnosis. So
and Paul, if I could, the NCCN guidelines do not include routine brain imaging as part of staging at the beginning.
Okay. Ben, would you like to comment on triple negative to the brain? Is there anything exciting on the horizon or in the clinical trial situation?
Well, I don't think specifically just for triple negative. I mean, I think there have been a number of trials that, particularly for HER2 positive, that have been going on, some of which are at your institution along with Dana-Farber. Nancy Lin is doing a lot of that stuff with not only looking at small molecule inhibitors. The thought now is that once you have an established MET, because of the tumor vasculature being more fenestrated or leaky, that maybe small molecules, or bigger molecules I should say, like antibodies, can actually have some efficacy. So that's a theory. It's still being tested, but there are a number of HER2 brain MET trials going on. For triple negative, I think we're still kind of stuck with what we have done historically. Surgery, sometimes we agree, an isolated MET. Our neurosurgeons are very aggressive about doing surgery for isolated metastasis, and sometimes even more. And then again, radiotherapy, whether it's stereotactic, whole brain radiation, or both. But beyond that, there's not a lot going on in that space, to my knowledge. I don't know if anyone else has other information.
Alphonse, no prognosis after radiation, just general comments?
Right. I mean, I want to go back to the original question. I mean, assume that she doesn't have any other metastasis, just an assumption, and assume that the brain is adequately treated, whether with stereotactic radiosurgery or with surgical resection. Still the question, what should we do locally? Now, we have a sort of like a good clinical response, which does not mean she has a complete pathologic response. Will you leave her like that? Will you leave her breast there? Or we need to do a local treatment to prevent a local failure, which will very much likely happen if we do nothing to the breast? I mean, this is the question. I would like to hear people's opinion about local treatment in the presence of distant metastasis, which is very minimal, or oligometastasis, which can be adequately treated.
Paul, can I say a few words on that?
Sure, absolutely.
So I think we all know there are no good trials to address this question. There's about a dozen retrospective trials, which are obviously biased because the patients that go to surgery are healthier to begin with, and in pretty much every single one of those trials, there's a benefit, and in some of them even an overall survival benefit. But as probably many people in this telecon already know, we tried to do the randomized prospective trials in that, and it failed because nobody wanted to be randomized in the non-surgical arm. There is another ACOSOG study that I don't know if it's still open yet, but we try to address this in a different way, where if someone gets systemic therapy and has a good response, then they get randomized to continue systemic therapy versus mastectomy or some sort of local control. And again, I think that trial has also been very, very slow to recruit. So when we get these patients, our kind of policy, and Barrett can comment on this as well, at Hopkins has really been, let's see how they respond systemically. If they have a nice systemic response, to consider it. But again, I don't think there's any good guidelines on this, and we've kind of done it on an individual case-by-case basis. I had a patient, for example, who had widespread metastatic disease, stage 4 de novo, ER positive, only bone disease, and got endocrine therapy for a year, and then asked this exact same question. She elected for mastectomy, and she actually had, by endocrine therapy alone, a pathologic complete response in the breast. Now, whether that was the right thing to do, we still don't know. But you know, there could be some utility for this. Again, it's really impossible to know right now.
Right.
Thanks, Ben. Can I please shift gears and let Dr. Campos from Fortaleza in Brazil present the second case? Dr. Campos, can you hear us? Dr. Campos?
Sorry, can we ask a question?
Yeah, sure. Go ahead. Ask the question.
Yes.
Yes. Would you agree that these brain metastases were there before, and probably the rest? I mean, the breast responded very well, but these brain metastases apparently did not. And maybe this bleeding was probably a result of the treatment. Sometimes we've heard of bleeding and metastasis for the brain when they get the treatment because of necrosis, etc. Would you think that the brain metastases were there before?
Anybody want to guess? Jack?
Yeah, I agree with that. I believe the brain metastases were there, and this is why I think it's a little unusual to say that they're progressive, because the data generated 20 some odd years ago suggested that in a naive patient, the response in the brain to a very good systemic response was not that different. It really isn't the blood-brain barrier that we think. It might be 10 or 20% less than a systemic response, but still quite likely to respond. So I guess I would, again, ask the question whether there's any role for neurosurgery to consider local treatment here, but I think these were perhaps even responding metastases.
I agree. Thank you.
Okay, thank you. Can we get Fonseca Campos, can you present your case, please, from Brazil? Have we lost it? Okay, we're having technical issues from Fortaleza. Rosanna, will you know? Or Myra, can you present the third case from Buenos Aires, and we'll wait to see if Dr. Campos can reconnect.
Okay.
Go ahead, Myra, when you're ready. Okay, Myra.
Okay. 42 years old, menopausal woman, previously healthy. She had disease, no cancer family history. She consulted because of nipple retraction and pain in the left breast. The ultrasonography and mammography was positive with virus 5. The physical exam was a lump, 8 centimeters, skin invasion, and nipple retraction. We had a axillary adenopathy, 1 centimeter, and we made the biopsy, and the stem cell study was negative.
Oh, forget that.
The diagnosis was ductal carcinoma, ER/PR negative, HER2 positive, and the treatment plan was neoadjuvant chemotherapy with PCHP for 6 cycles. He completed the chemotherapy and continued with trastuzumab until surgery, and the surgery was lumpectomy and lymphadenectomy. After the chemotherapy, the pathology was intraductal carcinoma 1%, negative lymph nodes, so she made a complete response. Now is with trastuzumab. And the question is about radiotherapy, and we want to know if necessary to practice the radiotherapy in this patient with complete response in the surgical site.
Myra, before we do the radiotherapy question, would somebody from medicine like to comment on her neoadjuvant therapy? Anybody? Brittany or anybody? Cesar?
Sure.
She was treated with neoadjuvant TCHP.
Yeah, I think that's one of the regimens that's been studied recently that's shown very high pathologic complete response rates, and is currently being studied in the adjuvant setting as well in a study Affinity, which will hopefully confirm if there's a survival benefit to the high PATR rates that we're seeing. So I think it's a regimen that's very commonly used.
I think it's quite uncommon in South America to give those drugs together because of the cost of the two. But that's very current therapy, Myra. So
Yes.
So we're hearing good things about the regimen and good complete remission rates. So the question about the radiotherapy.
Just want to make sure the patient had lumpectomy, not mastectomy, right? So the lumpectomy was negative. So assuming
Yes,
lumpectomy.
1%. We consider complete response.
Yeah, so if you had lumpectomy, you absolutely need breast radiation. That's 100%. The question will be, do we need regional radiation or not? And this is a question which is being answered by a randomized trial still open. I would assume that she had a positive lymph node originally. You wrote here 1 centimeter lymph node. I would assume that it was documented pathologically. So if the lymph node turned from positive into negative, this randomization in this trial will randomize patients into regional radiation plus, of course, breast radiation versus breast radiation alone. In the absence of the data coming from this trial, I would give regional radiation for her, which is the default, at least in, that's what we do here. And until this trial is out to show us whether we need regional radiation or not, I would recommend regional radiation, which will include actually supraclav, Agdella, and IMC. And the patient had a really very large tumor with skin invasion, so that's quite aggressive. So I would treat all the regional radiation.
Okay.
Okay, it's on.
No, I sent her an
Would any of the panelists like to make another comment about this patient with HER2 positive breast cancer who's got a good complete remission with neoadjuvant? Ben, would you like to say something?
Yeah, you know, I think I agree. With the lumpectomy, one right now has to still do standard of care, which would be to add radiation. And there was an ASCO abstract presented last year looking at the value of radiation to lumpectomy after achieving pathologic complete response, and there still seemed to be some value. I don't know if that's been published yet. So, but based upon that abstract, I would consider that this is still standard of care. And we do know pathologic complete responses for triple negatives and HER2 positive a good but not perfect surrogate marker for overall survival, but there can be in some series as much as 20% recurrence rates. So again, some of that is going to be local recurrence. And so I think one still has to do that. I do like the question of the trial ongoing, do you really need the same amount of radiation? And I think that's an important question to be addressed. But I think for right now, we still consider that standard of care.
Julia, would you like to say anything from your perspective? From you, Ben?
Oh, I agree with what Ben said. So standard of care is still to have adjuvant radiation therapy after breast-conserving surgery.
Right. So I think we've been joined by Dr. Campos again from Fertility. So Dr. Campos, we're going to go back to your case, and we're going to share the screen. And when the slides come up, you can start presenting the third case for this morning, please.
Hi, good morning. Sorry, I had some problems, but now I think it's okay. It's about a 31 young lady, premenopausal woman with a palpable left breast mass. With this mass, she went to a surgeon, and she had no comorbidities and a family history of her mother being diagnosed with breast cancer with more than 50 years old. So she had an imaging in the first quarter of 2014, ultrasound with a nodule with 1 centimeter per 0.4 centimeter at 7 o'clock localization at left breast. At that time, she didn't know if it was solid or cystic. So she had a fine needle aspiration that was negative, and she was asked to repeat another ultrasound. So she had another one, and then the nodule became bigger, 16.6 millimeters per 12.8 millimeters. So she had a biopsy. Really, she had this lesion taken out, and it was an invasive ductal carcinoma grade 2, 1.4 per 1.1 centimeters. Lymphovascular and perineural invasion were not observed, and negative margins, 3 millimeters. So it was a P1C NX at that time. Her estrogen and progesterone receptors were positive, HER2 negative, and Ki67 40%. After this procedure that was taken out, this lesion, she went to another surgeon, and the surgeon asked some more imaging, and she did ultrasound that showed breasts, dense breasts, BRAD6, and magnetic resonance that showed only the surgical bed and no lesion, BRAD6. She had genetic testing, and BRCA1 and 2 were negative. So she's a young lady with P1C NX luminal B left breast cancer, and she went to the second surgeon, and she wanted to have the breast removed. So the treatment, the surgery was left skin sparing mastectomy with sentinel node biopsy, and there was no residual disease, and only one node was examined, and it was negative. She had adjuvant chemo. I don't have the exactly cycles and period, but she had with adramycin-based chemo. So I brought this case because this lady was sent to me for a second opinion, really, and the questions are just for indications for post-mastectomy radiation. She has a very little disease, and if in this case with a skin sparing or a nipple sparing mastectomy, should we ask some imaging studies to evaluate the viscous tissue? Thank you.
Thanks very much. So, do you want to kick off with that last question?
Sure. So we don't routinely do mammography in these patients typically here. If you wanted to screen the breast, we sometimes would do a breast MR. Dr. Spector, are you routinely ordering that?
So I certainly think that on somebody who's had a mastectomy, they don't need imaging except for a clinical exam. You know, most implants are placed subpectoral, and so therefore if there's going to be a chest wall recurrence, it's very easy to detect via palpation. This is a woman, though, who is 31 years old, diagnosed with a breast cancer, and she has dense breast tissue. So it would be our routine to continue to follow the contralateral breast with yearly screening MR, and obviously that chest wall, we got to look at it. Some people ask the question of evaluating the implants with imaging, and there's varying opinions about whether doing an MR to evaluate the implants is important. However, keep in mind that an implant rule-out leak MR is different than a is there cancer in the breast MRI. Our plastic surgeons do not routinely perform MRI to evaluate the implants. We use exclusively gel implants that, in theory, we describe like a jelly candy, and so therefore can't leak. And any issues with the implants, again, they feel confident that we'd be able to detect this via clinical exam. And so if clinical exam changes, perhaps that would be a reason to add MR. We don't do routine ultrasound at our institution, but that's just kind of institutional based. There are many institutions around the country that are very good at whole breast ultrasound. But for her, we would be doing yearly MRI, and we would add yearly mammography at this point, and we would normally stagger them every 6 months apart. But when you talk to folks like Judy Garber, she doesn't think that that's totally necessary unless it's somebody who has a BRCA1 mutation. Even the BRCA2s that have a fewer incidence of interval cancers, it may not be as important. But we tend to stagger them in that it helps women, kind of feel covered throughout the process.
Would anybody on the panel like to comment about routine BRCA testing in an ER positive, PR positive, HER2 negative 31-year-old patient, please? Just your policy and what you think about it. Somebody?
Ben from Hopkins. That would actually be recommended here at Hopkins as well for someone this young. And again, as we know, BRCA2 carriers tend to have ER positive disease, whereas BRCA1s tend to have ER negative. So it's still possible that she could be a BRCA2 carrier. my thought on this is I actually think in some ways a lot of this is policy driven so that insurance companies will pay for it here. But be that as it may, I think for someone this young, we would probably have a low threshold for recommending this, even without a family history.
And we would also consider, and not always, but some people would consider P53 testing just because of the risks associated, potential risks of radiation exposure to a young woman who may carry a P53 gene. Again, it's super uncommon. We probably have a handful that we've treated before, but that would potentially make us sway towards mastectomy in lieu of lumpectomy. And so we would consider testing here for people diagnosed under the age of 35.
Can I just
albeit rare.
Can I just mention that Dr. Cynthia Villarreal, who is in Monterrey, Mexico, she was in Boston recently as a fellow, and she has started a young breast cancer patient clinic with some very carefully thought out and constructed research sub-protocols like fertility preservation, psychosexual behavior, a whole bunch of sub-studies underneath a database collecting information on very young women. So we are going to help her expand this to our network of doctors in this year, in 2016. So if anybody's interested in young breast cancer under the age of 40, please let Jessica and myself know, and we'll connect you with Cynthia Villarreal in Monterrey, Mexico. Alphonse, have we addressed the question of radiation here?
No, we didn't.
Okay, yeah, so would you go with that?
All right, so this is a 31-year-old patient who had a very, like what I think low-risk cancer. Like it's not grade 3, doesn't have LVI, the tumor is less than 2 centimeters. Overall, when you look at the literature, women who had mastectomy with negative lymph nodes and did not receive radiation, the risk of local failure vary between 7 and 8%, and this does not require any post-mastectomy radiation. And if you look at a cohort of patients within this series, women who have at least 3 risk factors, and 3 risk factors means like young age is a risk factor, positive LVI, like extensive LVI, close margins or positive margins, grade 3, maybe triple negative. Those subgroup of patients in these analyses will have a risk of local failure which will vary between 15 and 20%. So overall, the great majority of patients with negative lymph nodes after mastectomy, we do not recommend post-mastectomy radiation unless there is at least 3 high-risk factors. Now, there is a randomized trial which complete accrual. It's a British trial. It's called Supremo, which actually include women with mastectomy, high-risk node negative, which include at least 3 of the risk factors that I just said, and also the 1 to 3 positive lymph nodes, which was a gray zone area for a long time. And the data from this study is not published yet. So this study will tell us whether high-risk node-negative patients who undergo mastectomy, whether they need post-mastectomy radiation or not. But here at Mass General, we do sometimes give post-mastectomy radiation for node-negative, but only with patients who had extensive LVI or closed margins or any of the other factors. And just keep in mind that radiation can have a negative impact on the implant. The risk of a complication to the implant is quite high, could go up to 20 to 30%. So any patient with this reconstruction and that young, we really have to be careful whether the patient will benefit from post-mastectomy radiation or not.
Thanks, Alphonse. Anybody else want to make a comment about this interesting young patient?
You know, Paul, one of the things that I was going to bring up is whether or not there's Oncotype available, because this is a patient that I think one could make an argument for doing this. Young patient, you might want to spare her the toxicities of an anthracycline-containing regimen. It would also be someone that I would have a lower threshold because of being so young and you know, in terms of if it came back as an intermediate risk recurrence score, whether or not to try chemotherapy. But I don't know if that's something that our colleagues have available to them.
Can I just make a comment, says with a few more minutes? We have previously published on breast cancer outcomes specifically in Brazil, Mexico, and China. And we've also published on overall cancer outcomes all over the continent of South America and Latin America. And we see about twice the mortality rate for breast cancer in the entire continent and in all the specific countries that we've published on. And primarily it's related in very small part to access to medical care, but public versus private patients, it's really upstaging to stage 3 and 4. We see a large number of patients presenting with stage 3 and 4 disease. So very often on these tumor boards, we have the doctors presenting from very high quality urban areas, which have outcomes very similar, like the Fudan Medical Center in Shanghai, very similar to Mass General or Memorial or somewhere like that. But in the periphery, outcomes decrease substantially, mainly due to delays in diagnosis. And commonly, our tumor boards present a case that's kind of been mismanaged in the periphery at first, and then finally gets to an academic center, and then everything's done well. And so the standard of care between our panelists today and the people presenting the cases is very narrow. There's a very close proximity of care, but it's in the periphery. So I think if everybody that attends these rounds can invite the local doctors from the public hospital system to join these tumor boards, I think it's of more value to them than it is, because we're singing to the choir, so to speak, on these tumor boards. The doctors presenting here are really well trained, many of them in the United States. And the real problem is that the bulk of the population is in the public sector, where stage 3 and 4 is so common. And so it's nice for them to hear how their own experts would manage a case in the city that they refer to, or in the private sector they would refer to. In a study we did with Sergio Simone from Brazil, we found that the outcome, the difference between a patient's outcomes between the private and public sector was so large, it was the same as either giving adjuvant chemotherapy or not. It was actually larger than that. So it's a great disadvantage to the bulk of the population who are being treated in the public hospital system. So please let us all try hard to communicate with our public hospital colleagues or public hospitals that treat public patients, and we might be able to help them with more expeditious referrals and diagnoses, etc., which I think clinically downstages them and improves their survival substantially. So I don't know if anybody from South America wants to comment on this observation of ours, but Jessica can circulate the publications we've had. The ones I referred to were in the Lancet Oncology, but we have other publications on this subject with very severely bad outcomes in a lot of low-income populations and low-middle-income populations. Brittany, do you want to comment on this point? We can't hear you.
Yeah, I think my microphone's on now. Can you hear me?
Yes, thank you.
No, I completely agree with this point. I think, having more participation from people who practice in varied settings, I think it's useful for these tumor boards.
So if everybody that's presenting today would make an effort to connect their local doctors, either in the local hospitals or in the countryside, to our tumor boards, that would be extremely enrich the value of our tumor boards. So I invite those people.
Paul, would it be possible to ask Alphonse a question regarding this last case with regard to an outcome? So in Boston, there's some diversity of opinion as to the timing of radiation if one were going to give it. And namely, I've worked with experts who prefer to have the radiation done while the tissue expander is in place and before the final implant is situated. And others have presented data suggesting that radiation could await the final implant and be done at the end of all surgery. Do you have any preference? Because cosmetic outcome here, I'm sure, is going to be an important outcome, just as survival in this very young woman.
I think you are right, and I don't think that there is any style better than the other one. I think it's related to where you work. MD Anderson, they have their own style. Memorial, they usually exchange the the expander with an implant before radiation. Here we used to exchange the expander with the implant after radiation. And I think my sense is that all of them will have the same rate of complications. We are actually looking at our data right now. We have 400 patients who had implant and post-mastectomy radiation. I don't have the results yet, but we have all these different types of sequencing and different types of timing. So we really don't know the answer to that. But what we do here at Mass General, we are moving towards doing the permanent single-stage implant during mastectomy. And I have the feeling that majority of patients are going this direction unless it's necessary to do the expander. There is pro and cons from the radiation perspective. Sometimes when we have an expander, it's usually overexpanded, and this can impact the dosimetry, impact the quality of radiation. And what we usually do, we send the patient back to the plastic surgeon to deflate whether the ipsilateral or actually the contralateral, which can block the path of radiation when we do the medial tangents. Now, when you do the single-stage implant, usually it's done in a way which doesn't bother radiation. I mean, with all the patients we've treated so far, I had only one patient that the implant was very much medial, and we had to cross the midline quite a bit to cover the whole chest wall. But otherwise, they don't put an over or a larger size implant. Usually, they put the same size as the breast, or even a little bit smaller, or a little bit bigger, but still acceptable in a way. So to answer your question, we don't know what is the best sequence. I think all of them will have plus or minus, few percentage points, the same or similar complication rate. And it's now becoming a preference or a style that each institution will prefer its own style with a collaboration between the radiation oncologist, the breast surgeon, and the plastic surgeon.
But I think in some respects, let's be honest, every single time you make an incision, whether there's been an irradiated tissue or not, you're introducing a risk of infection. And so for the patients, for the plastic surgeons, and for the breast surgeons, if we can do this in one stage and minimize subsequent exposure to infection, it's been clearly shown that it increases the risk. And certainly operating on an irradiated breast is even worse. And so in our series where we published the first 600 nipple-sparing mastectomies, we had 70% incidence of having an immediate implant put in at the first operation. And so our plastic surgeons have been extremely pleased with this. Remember, each time they go in to have an injection of a fill of a tissue expander, that's a risk of infection. Some of our plastic surgeons only do it themselves, but they're introducing bugs that could potentially go into a foreign body. So I think our tide has turned where we much, much prefer that if we know the patient needs radiation, to get everything done in one step.
Jean, would you like to comment?
Yes, please. I agree with Dr. Tagian that I think that really the outcomes are going to be very similar depending on the sequence or the practice, and I think that it really does come down to the institution's kind of comfort level, and as long as you sort of follow an algorithm that everybody is communicating well with one another and sequencing things, to what makes sense for the individual patient, I think that is unlikely to impact the outcome. I think that I agree the ideal is to do the implant placement at the time of the mastectomy just to minimize any future procedures and eliminate the need for dealing with expansion and deflation and back and forth. But I do think that's a newer practice that hasn't been widely adopted everywhere. So I think a lot of institutions are still trying to manage this whole algorithm. My feeling is the only scenario where I think it is really important to think about doing the exchange later is when you have a patient that has very aggressive type of a disease, because when you do the exchange prior to the radiation, it definitely is going to delay the start of the radiation treatment. And there's really never been any study that's shown there's a particular cutoff that's really important or anything like that. But I think that we have a general understanding that, for example, a triple negative tumor, they tend to have an earlier recurrence pattern. So let's say you have a patient who had triple negative disease, they didn't have a good response to chemo, you feel that they're at high risk of local recurrence. That's somebody that I don't want to delay the radiation to get the reconstructive process underway. So I kind of think about that a little bit in terms of the sequencing.
Thanks, Jean. Julia, would you like to add anything? We can't hear you. Sorry, we can't hear you. Sorry, Julia, we can't hear you. That's it? Try again? No, we still can't hear. I'm sorry, Julia, we can't hear you. We might have to skip over that. Susan Sager, I saw you a late joiner. We had a very interesting young patient of 31 with given chemotherapy. And I'd just like to ask you if you've got any insights into fertility preservation in these very young women that are going to get chemotherapy for breast cancer.
Well, I think for a patient who has not had prior children and who desires that, that would certainly be something we would offer them, and trying to encourage them to meet with our reproductive team early in the course of their diagnosis. Yeah, I think timing becomes important, and so if you don't have those resources locally, you don't want to delay the treatment of their cancer. But I would say the majority of our patients who have not had children do want to meet with specialists, and many will go ahead and do procedures up front if we have time. More commonly, at least in my practice, I see many patients start with their initial surgical phase, and as they're recovering for surgery, at that point we'll go through their fertility treatments.
And you work closely and affiliated with the obstetricians in this?
Yes, yes.
Do you think there's a need for a special program for young women? Because I don't think fertility preservation is very widely practiced in South America as yet, and it's beginning now. So what would you propose? Special programs or what?
Yeah, I think that's very important. So number one is you need to have an OBGYN staff who's willing to work closely with the cancer patients. There's a lot of nuances that the team has to discuss. I mean, one is just what you can do to give them the best chance of conceiving later once they're completed their treatment, but also to understand what are the risks with future pregnancies. So I think the ideal model would have a whole team of people that, kind of like a tumor board, meet to discuss the case and whether they do it remotely or whether you can put all those people in one room would be helpful. I think to point the genetic makeup of the patient, so to have genetic counseling represented in addition to the home care coordination team would be helpful.
And I always like to put a plug in for Dr. Yanin Shivari from Mexico City, who is collaborating from South America on a research study of BRCA1/2 testing with one of the doctors in the United States. And she's looking for collaborators. So if anybody does not have access to BRCA1/2 testing, please feel free to contact us, and we'll help connect you to Yanin Shivari and Dr. Weiner on the West Coast. I think it's City of Hope. I'm not sure where he is. Anyway, are there any other comments? Because we ran a bit quickly this morning, and we fill the whole hour with 3 cases, but we got through them quickly. So any other general comments, please?
Can you guys hear me? This is Jean, right?
Yes, Jean.
Okay, good. For some reason, my microphone was on mute before, so I wanted to just go back to the case with the patient who had the pathologic complete response and the question of whether they needed regional lymph node radiation. I just think that if I remember right, the case had skin invasion, and so it was classified as a T4 lesion. And also I think it was classified as N2 because the adenopathy was bulky. I might not be remembering it correctly. But for those patients who have that very locally advanced disease with T4 in particular, they're not actually even eligible for that trial because the sort of premise is that with these super locally advanced cases, we should be radiating them. So I just wanted to second what Dr. Tagian was saying. In that particular case, despite the good response, I think radiation, you would do it, and even in the setting of a clinical trial here, that patient may not have been eligible. because of just how advanced the disease was.
That's great. Thank you. You got any other imaging insights for us?
I don't think so.
No, okay.
Unless there's a specific
all right.
question.
Unless there are any other questions, I think we're going to end early, and just thank you all very much for attending. Thank you very much. Thanks for coming, guys.